Hello, everyone. Good afternoon. I'm Allison Elsner. I'm the CEO of Inland Wellness Information Network, or IWIN, as well as San Bernardino County Medical Society, or SBCMS. We are very excited to have you here today for our second session in our Food, Health, and Cultura session. And we are equally excited to welcome back our program director, Dr. Angie Romero-Neeson. Dr. Romero-Neeson is a quadruple board-certified physician who is passionate about advancing health equity by amplifying the expert voices in medicine, where health, nutrition, culture, and lifestyle medicine can intersect and advance chronic disease management in a culturally adaptable manner. Dr. Neeson, we'll turn it over to you.
Okay, thank you. You can go ahead and go to the next slide. All right, here's the information for the CME for those of you who applied for it. We'll also give you instructions at the end if you miss it. But I just briefly want to introduce my amazing Latino colleagues in case you missed last week's session. Dr. Sandra Indacochea Sobel is a triple board certified endocrinologist, obesity medicine, and lifestyle medicine specialist. She is also the CEO at Summon Health in Pittsburgh, Pennsylvania. Dr. Antonio Miranda is not only a registered dietitian and diabetes educator, but also the world's expert on Latino health behaviors, especially machismo studies. He is a national speaker and consultant and works with many health experts while residing in the greater Dallas area. Dr. Robert Graham, also known as Dr. Rob the Chef, is also the only Latino physician chef I know. He wears many hats, including being Chief Health Officer at Performance Kitchen and co-founder of Fresh Medicine. He's also the director of integrative medicine at Catholic Health, where he sits at the intersection of integrative medicine, food, and public health. And lastly, Dr. Sonia Ponce is a fellow San Diegan like myself. She has a master's in public health, where her research projects on Latino health, lifestyle, behavior modification meet preventative cardiometabolic health. She's the owner and founder of her community cardiology practice, where she continuously focuses on empowering her Latino patients with culturally appropriate lifestyle changes. Go ahead and go to the next slide. These are some of the many objectives that we have, but we would like for you to explore a variety of ways, habits, ingredients, food preparations that incorporate Latino tradition and heritage to encourage and empower healthier living. Next slide. And I just want to bring to light that when I say Latino, it also includes Latinas, Latine, heritage. The Latino name is just a global term that many of us use. We may call ourselves Hispanic, Latino, or Spanish heritage, but we're not all the same. These are our speakers today. They're in bold, but we have other speakers for the rest of the series, and you can see that we're all from different parts of Latin America. And even if when we were part of Mexico, even many of us have subcultures with incredible heterogeneity and cultural diversity. All right, so I want to start us off with a poll that this is something that hasn't really been in the news as much, and this is what makes all of us here so happy. Does anybody know of any community members, friends, family members who actually have reversed their diabetes? Let the poll go a little longer. Couple more seconds. Okay, go ahead and end the poll. So 58% of you said no, and 42% said yes. So I'm really happy that at least almost half said yes. So what we're going to do is we're going to go through, here, I'll share the results with you guys. There we go. Okay, we're just going to take you through the lived experience. So go to the next slide, and I'll have Dr. Sandra take you through, Dr. Sandra Sobel take you through some of the highlights, the studies, the statistics, and we'll take you through this journey. Go ahead, Dr. Sandra.
Thank you so much. And thank you everybody for joining. And I think when we're covering, especially the focus being cardiometabolic and obesity health today in our communities, going through some of these statistics. So the slides that I'm going to show you, the next couple of slides, come straight from the CDC's website. And this is sharing with you age-adjusted prevalence of diagnosed both diabetes and obesity. I think we've independently seen diabetes and sometimes independently seen obesity. What I liked about these slides is that it shows both on the same map, and we're just going to compare 2004 to 2019. So starting with 2004, next slide, please. Looking at the map of the United States in front of us. And again, this is by county. So looking at also the guide on the lower right corner, we see that as we have more intense blue color, that's indicating a higher prevalence of obesity in those counties. If we see a more intense red color, that's indicating a higher prevalence of diagnosed diabetes in those counties. And if we see intense purples or going more toward purple, that's a combination of higher prevalence of both obesity and diabetes. We're hearing this term get thrown around more recently of diabesity. But here's what the map looks like. We see a lot of, my impression, a lot of blues spattered throughout, some pinks, and some purples starting to cluster in the Southeast region. Next slide, please. So we take it to 2019. And all of a sudden, we see pretty much of a purple wave starting to take over the United States, which obviously is concerning. And I want to draw attention to the Southwest, where we see clusterings of purple. We see also in the Pacific West, Northwest, some clusterings of purple, some in the lower sections of Texas, you see there in the southern regions of Texas, and also the Southeast still. Next slide, please. And so this is taken from the Pew research. And what we see here is a 2020 map of the Latino population by county here in the United States. And the more mustard color is where we see higher concentrations of Latinos. And so we can see that also concerningly, it tends to be in some of these really intense purple regions that we saw in the map before. Next slide, please. So when we're talking about cardiometabolic health and how to assess someone's risk, I think it's helpful to go over what we can use, tools we can use in the clinic. And so one tool that frequently gets used, honestly because of ease, is the body mass index. And so in large scale epidemiological studies, it is something that is very easy to employ, and in these large scale studies can be helpful. I think it's also important to recognize its history and also for the individual person, why it might be imperfect. So first of all, this tool was developed in the 1800s by a mathematician, and the standards we had were based off of white European males. And this has just been a measure that we've been using over the several centuries. And it became really popularized in the mid-1900s by Ansel Keys, again, using measure cutoffs that were determined in what was like a normal person based off of white male Europeans. And so while it's easy and cheap, it is imperfect in its sense. But it's something that still is used and shows up a lot in guidelines. What I would encourage individuals to do is invest in a tape measure, because that also is a cheap way, but offers more information when it comes to cardiometabolic health. And so waist circumference, and where the Obesity Medicine Association encourages, and what I use in my clinic, is using the top of the superior iliac crest and really measuring it, the waist circumference around there. What is referred to the guideline for threshold of waist circumference in men is 102 centimeters, and in women it's 88 centimeters. Now you'll see that I have 97 centimeters there, and you can see the reference there on this slide. This actually comes from a large-scale study looking specifically at a Latino population. And what they found there was actually the threshold for Latina women was 97 centimeters. So again, drawing attention to the fact that there are heritage, there are ethnic cutoffs that pertain to specific ethnic groups. And so here in the Latino population, 102 centimeters for men and 97 centimeters for women. Now, also consider getting a waist to hip ratio. And what we know too is that if someone has a lower waist to hip ratio, that is considered to be more protective against cardiometabolic complications. And here you see a table provided by the World Health Organization for certain cutoff points and risk of metabolic complications. Next slide, please. So beyond the physical exam, well, what are some lab values when we're ordering labs to try to understand and assess cardiometabolic risk? And there are multiple ones, but trying to think of what are these that are standard and insurance will most likely cover. Well, starting with the hemoglobin A1C. So let's review the importance of and what these thresholds are. So for prediabetes, when we're talking about the hemoglobin A1C, prediabetes is defined as 5.7% to 6.4%. And I really want to stress that this is something that should cause alarm if we see an A1C between 5.7 and 6.4%. Unfortunately, frequently it can just be brushed aside and been like, oh, well, it's borderline diabetes. Let's not use borderline diabetes. Let's define it for what it is. It is prediabetes. And this is where we need to intervene ASAP to prevent the progression to type 2 diabetes. Because if we dismiss it and say, oh, it's just prediabetes, then we might be giving this message to our patients that we're trying to treat that it's not a big deal when it is a big deal. And this is the easiest time to intervene and reverse it. Type 2 diabetes and type 1 diabetes is defined as an A1C of 6.5% or higher. When looking at the lipid profile, we are specifically from a cardiometabolic standpoint, paying a lot of attention to the triglycerides, as well as the LDL, knowing that high LDL increases plaque buildup both in the coronary arteries and the cerebral arteries. And so understanding what the goals are in keeping triglycerides less than 150 milligrams per deciliter and the LDL cutoffs too, ideally less than 100 milligrams per deciliter. Liver function enzymes on a complete metabolic panel is something that I look at and pay a lot of attention to specifically. So ALT, when that's higher than the AST and above the reference range, when the ALT is higher than the AST, that is an indication that there might be some underlying metabolic dysfunction associated liver disease, formerly known as non-alcoholic fatty liver disease. So paying attention to those numbers is very important. So why am I bringing attention specifically to those blood levels? Because underlying all of those is insulin resistance, the concern for insulin resistance. And so insulin resistance from a nutritional standpoint, we're really trying to target someone's macronutrient intake, specifically reducing ultra-refined carbohydrates. So what causes insulin resistance from a nutritional standpoint? Excess, consistent use of ultra-refined carbohydrates. And I'm stressing ultra-refined because the knee-jerk response should not be low carb, right? We need to do low crappy carb, low bad carbs. That's what we need to keep low. But complex carbohydrates give us more. That's what we need to feed our body. Okay, so complex carbohydrates are not the enemies. Ultra-refined processed carbohydrates are. And what we don't talk about enough, is also overconsumption of saturated fats. So we need to be having this discussion with our patients too about lowering saturated fats, because overconsumption of saturated fats combined with ultra-refined carbohydrates, this is leading to insulin resistance. Physical activity, sedentarism is also leading to insulin resistant movement. I'm aware, right? That's going to help promote insulin sensitivity, and we need to communicate that with our patients. And then obviously always review medications with each of our patients, specifically looking for the obesogenic medications, some of the common players that we know of, glucocorticoids, corticosteroids, most certainly. But we also need to be thinking of other medications that are obesogenic. For example, diphenhydramine, if people are using sleeping aids, frequently diphenhydramine is in these sleeping aids. Those are obesogenic medications, and we need to be aware of what could be promoting excess weight and insulin resistance. Next slide, please. Great, Angie, I'll pass it to you to do the poll. Well, I'll read off the question. So have you heard that tortillas are the cause of increased diabetes and obesity?
Okay, Dr. Ponce. I'm going to have you present a little bit of why this word is a pet peeve of ours in the Latino culture, because we often hear that we're told that our patients say, oh yeah, I've been trying to cut down on tortillas or bread or whatever. And some of it is ingrained in our culture, and some of it is something that we just grew up with. And what bothers me is that a lot of people blame the tortillas when it's not really the tortilla. So I'm going to have Dr. Ponce explain how she talks to her patients about this. Next slide.
Sounds good. Yeah, thank you. So thanks everybody for joining us today. Welcome back. And if you're new, thank you for joining us and thank you for your interest. So I have to say that there isn't a single day that goes by when I have a patient coming in and I'm trying to talk to them about their diabetes. I'm going to use the term diabesity because I think it just merges very well. We're dealing sort of with very close together problems. So in trying to speak with my patients about this problem with obesity and diabetes, and when I bring it up, the first thing that comes out of their mouth, ay, pero ya no como tortillas, I'm not eating tortillas. And I have to say that this is incredibly hurtful. For me, especially coming from individuals that tortillas have been a part of their diet from the beginning of times. I mean, you have to remember that tortillas have been available in our culture for centuries, even before the Spanish conquistadores set foot on the land. And back in the day, we were not dealing with the issues of obesity and diabetes that we're encountering today. We have to really identify the real enemy here. The real problem is not our tortillas and traditional food, but rather the consumption of processed foods. Next slide, please. So I wanna move on to talk about cardiovascular health. And I like to change the tone here. Instead of talking about cardiovascular disease, I like to focus on cardiovascular health. The reason for that is because if you say cardiovascular disease, I feel like it brings quite a bit of fear and concern in our patients. And they already walk into your office thinking about, oh my God, I am going to have a heart attack. But if instead you embrace the patient, telling them about cardiovascular wellness, cardiovascular health, how we are born with perfect cardiovascular health, and that we are there to try to help them preserve that which they were born with or improve whatever might have gotten out of control. Cardiovascular disease, as we know, is a leading cause of death in the United States, and unfortunately is strongly related to our lifestyle choices. And those choices, again, is not the traditional diets that we had, but it's really the adoption of newer diets strictly related to the consumption of processed foods. Diabetes is equivalent to cardiovascular disease. And as a risk factor is the leading cause for heart attacks and strokes. Unfortunately, the Hispanic population carries a high burden of diabetes. And I really want people to continue to remember that diabetes for a person of a Hispanic background is an incredibly scary term. So once you diagnose somebody with diabetes, the terror just sets in, oh my God, I have diabetes. Because they've all seen somebody who ended up with amputations or terrible outcomes, ended up blind, and their quality of life just is completely destroyed. So we just have to be mindful of how terrifying diagnosing somebody with diabetes can be. most importantly, it's important to give hope to the patient. So when you have made a diagnosis, remember to go back to say, hey, you know, we have ways to help you. We can move you forward from this new transition into diabetes to no diabetes and to regaining cardiovascular health. When we talk to our patients, our Hispanic patients, about diabetes, we also have to be very sensitive to cultural beliefs, specifically when it comes to food. Again, just going back to that tortilla example, and there are many other examples on this, let's not blame our cultural, our traditional diets, but really focus on the true, real enemy. One thing that I wanted to make sure I discuss on this conversation today is the fact that our cardiac exams, especially when they turn out normal, doesn't guarantee a patient is not going to have cardiovascular events. I often have patients that come through sent, you know, by my primary care provider colleagues asking to be screened for cardiovascular disease. And we go through the usual testing with echoes, stress echoes, carotid artery studies, vascular studies, et cetera. And the studies might look normal. But one thing that has to be very clear here is that if your patient continues to have uncontrolled diabetes, we haven't really saved that person. So it's really important for me when the patient receives the news that everything looks good, thank goodness, your heart looks great, you have good functional capacity, there's no evidence of significant cardiovascular disease. However, you do have diabetes, and I really want you to focus on fixing that. So let's work together on taking care of that. Next slide, please. The power to put diabetes in remission. We had a poll where we saw, I think most people had not met somebody who had managed to put their diabetes in remission. I'm fortunate to have seen this happen in a very good number of my patients. So I'm going to walk you through some of the things that I do in clinic to try and help patients regain cardiovascular health and improve their diabetes to the point of putting it really into the remission status. Another big point here is you have to remember that cardiovascular risk reduction is equivalent to our ability to stabilize glucose in your patients, and that prediabetes remains a risk for cardiovascular disease. I have a ton of patients that come in, we talk about their A1Cs, we clarify what it means, and they said something like, I see, doctora, I've always been there, I've always had prediabetes, and that is dangerous. It almost feels like, oh, I've done a really good job because I haven't gotten to diabetes. But the fact that they've had prediabetes for a long time places that person at risk. Remember, this is time of exposure. So the longer the time a person is in prediabetes, the higher the risk that person is going to develop cardiovascular disease. So exposure time is incredibly important. Again, talking about food choices. So no, we should not take food away from our patients. It's really about feeding them the right foods, teaching patients about what is it that they shouldn't eat. Another example here, I have patients that come in and say, pero doctora, I'm eating very lightly. Okay, well, tell me what you're eating. And it turns out they're having cereal for dinner. So, you know, I might as well have them eat their tortillas and beans and take away that box of cereal that is full of added sugar. Again, all boils down back to education. I have to say that I have relied heavily on some of the newer anti-glycemic agents. There is evidence that this new medications have benefits in cardiovascular death and cardiovascular risk reduction in general. And even though this discussion is really about lifestyle choices, I have to tell you that lifestyle alone in patients who have advanced diabetes or that have struggled with diabetes might not be sufficient. But as clinicians, as healthcare providers, now we have this tool at our disposal, and we really need to, if we have access to it, we really have to maximize its benefits. May I have the next slide, please? So just a few tips from what I do every day. First step, I think the most important thing here is that we develop trust with our patients. So patients need to know that you have their best interest in mind. And then also just make an effort to embrace their culture, their traditions, their diets, at least their traditional diets. Then the next thing is in communicating with patients, food is always a very sensitive topic. Nobody wants to be told what to eat and how to eat. So you do have to be as gentle as possible, yet consistent. So keep things simple, keep it consistent. Everybody will agree that junk food is probably not good for you. And everybody can recognize it. So I just speak about avoidance of processed foods. Dr. Graham in the past has used the concept of if it comes in a package, it's probably not good for you. I do the same thing with my patients. So I have them focus on increasing their intake of vegetables. I give them a visual so they can see a plate and they can see that they should be aiming for at least 50% of their plates to be vegetables. We talk about simple carbohydrates and trying to keep that low. And I always give them an example of what we shouldn't be eating. One of the good ones that I like to use is that no tortas de chilaquiles, okay? So we have to just be mindful in keeping those down. Absolutely no sodas, no juices. And throughout the whole process, I do my best to remain non-judgmental because the moment the patient walks in, if things have not gone as planned, they're gonna say, ay, me van a regañar. And that's not it. I'm not there to make them feel uncomfortable in any way, but rather to celebrate their successes. So if a person comes in and they didn't reach the goal they were aiming for, then we have to focus on what they did well. So if they didn't lose, okay, fine, at least they didn't gain. And if they gain, okay, well, it's an opportunity to do better the next time. So you have to kind of turn into a cheerleader for your patients. Okay, have the next slide. I just wanted to end the discussion with one of my patients, and I have several, but this one is very dear to my heart. This was a woman that came in with heart failure with preserved ejection fraction and the whole syndrome presenting with dyspnea on exertion, very low exercise capacity. She was very fluid overloaded with pretty significant edema, orthopnea, PND, suffered from obesity, and her diabetes was uncontrolled, had been using insulin for more than 30 years along other medications. So about a year after, she made some changes to her diet, and it wasn't anything crazy. What she managed to do is avoid processed foods, be careful with her carbohydrate intake. She couldn't walk much because at the point she was using a walker, but just simply increasing a little bit of physical activity in addition to GLP-1s, which helped me take her off insulin. Pretty soon after the initiation of this interventions, she lost a significant amount of weight. I was able to get her off a number of her blood pressure medications. And more or less at about 1 year, she had lost a little too much weight. I was worried about frailty, so I had to take her off the GLP-1s. Surprisingly to me, her diabetes was essentially gone. Right now, she's managing her diabetes only with lifestyle and metformin, and she doesn't have heart failure symptoms. So she's one of the many patients that I have had the fortune to improve her quality of life, get rid of disease, and make her just feel empowered. So with that, I'm going to pass it on to my colleague, Dr. Miranda, so he can carry on this conversation.
Thank you. What a great story. I have a story of my own to transition to what I call la mera neta de la diabetes or diabetes, obesidad. I haven't ever heard it in Spanish, but I'm very pro-education as a dietitian, certified diabetes care and education specialist. I love the fact that when doctors and clinicians are able to refer to us, and I would encourage all of y'all to look for dietitians, look for CDCESs, look for programs that are approved by the Association of Diabetes Care and Education Specialists, because we hear all these stories all the time. And I love working with my Hispanos because it really empowers them. What we take for granted of what is a chicharrón? Is a chicharrón better than a tortilla? Does tortillas, frijoles tienen carbs in them, right? So all this stuff is important to decipher, especially among lower literacy populations. And the story that I wanted to share is that I saw a patient many years ago, and he was newly diagnosed with diabetes. And that same weekend, he goes to a chicharroneada. If any of us from northern Mexico know what that is, the chicharrones that you see there in the bottom right. It's a Mexican barbecue. And I asked him, what did you eat there? Because he said, oh, pues I couldn't eat chicharrones. No iba a comer chicharrones. And it triggered my brain. I said, oh man, what did he have to eat instead? And he goes, pues fui y me senté con mis hijos y me comí un platote de fruta. And I asked him, ¿a cuánto le subió el azúcar? And he said, 400. And I was like, what a great learning experience. And I didn't use that experience to demonize fruit. Fruit is not the issue, right? Tortillas are not the problem. Fruit is not the problem. But the real problem is the lack of education among our communities. And that being said, I helped them reframe and understand. If you go to the chicharroneada, if you go to the barbecue, you can have some chicharrones, not all the time, as Dr. Zobel said, with the saturated fat, but the picadillo, the salsita, that's all vegetables. You can have as much of that as you want. You can have the calabacitas, you can have the nopales, you can have a couple tortillas, you can exercise that morning. And sure, you can have the fruit, but don't get a big platote of fruit and without going into, you just ate 150 grams of carbs and your blood sugar spiked to 400. So education is the number one thing that we can encourage. Transitioning on to what I call la mera neta de la diabetes in our populations. We talk a lot about how the Anglo diet has negatively influenced our dietary culture, but as cultures coming from other countries, it's also beneficial to learn from each other because we're coming from countries where my abuelo worked in the rancho behind a plow. If you brought him to the US, he would never step foot in a gimnasio, in a gym. A gimnasio doesn't exist in the rancho, right? A gimnasio doesn't exist in a lot of low-income places. So what we can help our populations, whether you call it acculturation or retroacculturation, we have to start changing our culture from within. And let's talk about some of those. So first one, we've got to normalize exercise. For various reasons, we don't like to exercise. Sometimes it's very valid reasons where these hardworking house cleaners, construction workers are dead tired at the end of the day. I mean, I worked as a roofer when I graduated college before I started my master's. I can't explain the craving you have for sweets and candies and chips. But again, for those who are not active in manual labor, it's encouraging them to exercise, normalizing exercise. The second one, and not to harp on it too much, but what everybody else is talking about is that lower processed food, the return to rancho diet. Yeah, it's not la tortilla no nos está matando, but it is the 15 tortillas, right? Back when we were very active in previous times and not living in urban areas, we managed how many tortillas we were eating. And we could get away with eating more because we were having to work for that food. But now the convenience is what's making it really difficult to maintain our health. Also, we can encourage all of those nutrient-dense foods that we've talked about, and also helping patients overcome the barrier of affordability, helping patients learn about the resources that are in the community, but also helping them understand, oiga, no necesita gastar dinero para llegar a su meta. Los frijoles, los nopalitos, las lentejas, el chile, all of that is very affordable stuff. And what's also very affordable is not going out to eat as much. So it's a constant, what I call it's a little verbal sparring match that you're having respectfully with your patient, where you're encouraging them, you're being compassionate, but you're helping them reframe some of those hindering beliefs. And then from there, let's see here, normalizing pharmacotherapy, what I called last week insulin resistance, right? Many of our patients, especially in Hispanic culture, we have that insulin resistance to no insulina. But what about, I've seen a lot of great potential just psychologically. The idea of a once a week injectable with the GLP-1s, a lot of patients seem to be more open to that. And given the latest ADA standards of care, those can be first line treatment depending on the insurance coverage of the patient. So having those conversations, and really, if you help one patient, you've helped 20. Because when one patient loses weight and gets healthier on a GLP-1, just like we heard previously, well, guess what? The 50 family members of that patient are going to ask her, pues, ¿qué hizo usted? ¿Cómo la hizo? And there you go. Now you've got the snowball going. And then for us as healthcare workers here, I have at the bottom, remember that individuals have autonomy over the environment. Just how the environment really impacts our decisions, our individual decisions can help us overcome that. The number one thing we do as dietitians and as diabetes educators is empower, empower, empower. You want to validate the barriers that the patients are going through, but at the end of the day, whether you're rich, whether you're poor, whether you're living wherever, we all have different barriers and different advantages and disadvantages. Validating the disadvantages that your patients express, but also empowering them to overcome their environment. So just next slide, please. Don't worry, I'll go through the next ones kind of quick. So here we go. This is a bit of a funny slide. The Anglo diet has influenced us, but we've also influenced the Anglo diet, right? Because I see a lot of patients that are rural white, and they say that their little teenage sons and daughters, guess what they're eating? Does anybody want to take a guess in the chat? What are the popular chips that all the teenagers are eating that are not from the United States? Takis. Just how we as Hispanics struggle with la dieta de la té, tacos, tortillas, tostadas, tamales. I love that phrase, la dieta de la té. We've also influenced U.S. culture in that now all the teenagers are Takis, right? All the Mexican candies blown up. So we have to take a step back and remember we're talking to human beings here, no matter who you're talking to. So next slide, please. In the last about 5 or 7 minutes that I have left, I want to expand on some of the most common social determinants of health that you'll see in the Hispanic population. I conducted a study, and it was probably the best experience, or it was the best experience of my life to date, where if you ever saw the show 100 Mexicanos Dijeron, it was practically 40 Mexicanos Dijeron, where I interviewed these rancho Mexicanos living in the U.S., lower socioeconomic status. And to pause and not talk the whole time, what do you guys consider the biggest barrier for your Hispanic patients? What are the greatest contributors to their health struggles? I'll pause for a second. Type it in the chat. Quickly now, if you can. Access to healthful foods. Yep, that's a very popular one. Let's see one more here. So access, right? The food swamps, access to food that is culturally appropriate. Yes, so all that stuff. Yep. So I'll give you the summary of what the Hispanos told me, and these were all men, right? So we can't generalize too much, but ultimately they think healthy food is expensive. Yeah. So the different perceptions. Remember, when you think, why do Hispanics struggle with their health? And I asked them, ¿por qué? Think of Corpus Christi down in South Texas, where we have diabetes prevalence in certain counties over 50%. And this is the acronym that I came up with. Cultural customs, right? La dieta de la té, which we'll expand on. Origin, formation of health behavior. There was no gimnasio back in the day. There was no dieta because you simply didn't have enough to eat. So we never trained oftentimes those self-impulse regulatory mechanisms without getting too neuroscience-y. A reactive health culture. No, pues ya cuando pase algo, me cuido. And also the paradigm shift, right? From going from Mexico and all of these other Latin American countries to the super stressful con el reloj, el trabajo, los biles. Houses are $500,000 or more. That stress is very difficult for our patients to deal with. And also simply the generational transition, el mercado, the global market has made access to food so much easier, not necessarily the old traditional food. And of course, socioeconomic status. Next slide, please. So I just wanted to expand on some of these. So cultural customs, what do I mean? Because cultural customs can be positive, but they can also be negative depending on how much we eat. So I asked 40 men, and this was the most common answer. What men should not eat to avoid diabetes is all that our food culture in Mexico has, which of course he's wrong on that. We have plenty of healthy food, but it's la dieta de la té, tortillas, tortas, tamales, tacos, tostadas, everything with the T. That's what we eat. But again, I ask you, it's all about portion control. There is no magic in all of this. It's all comes down to portion control and how we can help patients achieve that. And this next one is probably one of my favorite ones, the origin formation of health behavior. Where are your patients from? Most of us come from poor origins. Somos humildes. So many of our patients, the world has changed so fast. So many of our patients that immigrated here from the rancho, they didn't even have enough money to buy a cookie. They didn't see a galleta till they were 20 years old. My dad didn't drink a soda till he was 16 because he couldn't afford one. And imagine going from that to now having all of the McDonald's and the CC's pizzas literally across the street. So it's a lot of work and a lot of interprofessional care. We could expand, and I'll share the article in the chat, and I could expand for hours on this. But ultimately, we have to remember, listen to your patients. Is this a psychological thing that they might benefit because they're having a difficulty with their acculturation in their marriage with their kids, and maybe seeing a counselor will then help them with the healthy behaviors? Or is this an educational thing, and maybe I need to refer them to someone else who has the time to educate them, or maybe to the endo, so on and so forth. We do not throw away comida. Yes, so cómete todo en el plato. Next slide. I'll wrap up here just momentarily. One more slide. Let's skip ahead. And this is a very powerful slide, perhaps the most impactful slide that I share during conferences. And this is a very morbid thought that life in the United States for the majority of Hispanics nos acaba. And that's a very honest, very vulnerable position that person put themselves in, or that person exposed themselves to. He said, we've got a family to feed in Mexico, a family to feed here, biles para pagar, my kids need to go to school, my kids need to go to college. But remember to tell your patients to focus on themselves too. You can run 110 miles an hour until your heart gives out. You can run 110 miles an hour until your pancreas gives out. So again, empower, empower, empower. And last slide, for me at least. My simple tips for you when working with your patients, but again, send them to certified diabetes care and education specialists, dietitians, and all that. This is a visual that I show my patients, and I would encourage you, have good handouts, kind of like we saw previously. A lot of our patients can't read, right? We have a very heterogeneous group of very high literacy Latinos, but very low literacy. You should be able to explain, or we should be able to explain to our patients carb counting if they're that advanced. And again, you won't have time in 5 minutes. But then also in the clinic, I show them images, strict images, because how are you going to teach someone take 15 grams of carbs when you have hypoglycemia if they don't know how to read and write? I always share the story that I drew a lunchbox and drew the food inside the lunchbox and said, this is what you do when you're feeling like this. And you have to use your wit and your resources. And next week, we'll talk a little bit more about dichos and how we can use these colloquialisms to help deliver these health messages. So that's a bit of a crash course on the social determinants of health for us, and hope you guys are enjoying. Let's go to the great Dr. Rob. Thank you.
All right. Oh, you got one more, I think.
Yeah, actually, I wanted to go back to that slide. Let me share a resource that I usually talk to patients. I like the plate idea, but my story is such that I knew what fiber was since the age of 5 because my grandpa had diabetes and my mom was the only one who spoke English and Spanish when she went to the dietitian, and the dietitian said, eat more fiber. And so my mom sort of immersed that, and that was the thing of how to control the diabetes was more fiber. So I like this full living plate course. It's completely free. You can give this to your patients. You can give it to anybody. But the idea is that the plate is 75% fiber and 25% whatever else you want. So if you kind of just imagine that, in the Latino culture, we have a lot of different sauces, which have the fruits and the vegetables, the salsas. It's not going to look like a plate where it's like 25%, but it's sort of the idea of, more than not, more fiber. All right. It's up to you.
All right. Well, thank you so much. Again, blown away just listening. I never want to be first because I always want to, I learned so many of these nuggets from you guys. So dicho. So let me start with a dicho here. So many people hear of this famous food writer, journalist, Michael Pollan. Most people think of him as, I think, the most important 7 words in the good food movement that we're all sort of talking about. Eat real food, not too much, mostly plants. So every time I give a talk, people ask me, what is your advice? And I said, listen to Michael Pollan. But I also love this quote here. The more we honor cultural differences in eating, the healthier we'll be. And, you know, just going back to the lived experience, next slide, please, is really about this interplay between the structure that we face, the culture we live, and the agency that we build for ourselves. And I think this is really important when looking at sort of marginalized communities. Latinos traditionally are a marginalized community. And I think trying to advance where healthcare is still so far behind in terms of the patient-centered approach that you often hear, but really expanding it more into the culture-centered patterns of eating when looking at the patient-centered approach. Now, one thing that really became clear when after hearing all you amazing people here is that everything that we try to do takes time, but yet in the clinical setting that we are forced to be in, time is of greatest value, right? And so how do we do this? And I often say that if you go to a kitchen, the executive chef usually is just putting out the meals. It's really the people behind the line, the person on the meat section, the garden section. There's such a team involved in a kitchen. And I think in healthcare, we often see it just as the doctor or the dietitian. But I think we all agree here that we can't do this alone. And oftentimes it's really the patient at the center that we have to honor, but particularly their culture that they come in with. And I love this quote. Next slide, sorry. As I mentioned last week, right, that food is intrinsically related to human and social interactions and community. If we celebrate my lived experience with heritage foods, I honor my health. This gives permission for others to do the same. And this is by the famous Angie here. And if you pop the slide here, and I just want to share this picture. I shared it last week. And oftentimes, if you look at here, this is one of my initiatives that we started, a movement called culinary medicine. This is probably about 15 years ago. And these are doctors. And you may not recognize them as doctors because they're smiling here. And most doctors, you know, when they work together are not smiling. And they're cooking and they're having a great time. And what I love about this picture here is that if you take a deeper look into them, they are from all cultural backgrounds, right? And so coming around a table, cooking together, and I often do this, and I love, I believe it was Dr. Sobel's clinic has a teaching kitchen in it. I think people really, I learned my greatest lessons about health and food, not in any sort of office, not in any sort of not in any classroom, but at my mom's table, right? Those greatest lessons that I learned about the importance of health and the connection to food really happens at home in our kitchen. So this is one of my favorite pictures, but I really believe that if we honor our culture, we will be healthier. Next slide. And as you've been hearing, you know, we hear mostly today's conversation about the Latino experience through the lens of the Mexican kitchen. But as you know, as Angie shared in one of her first slides, is that we are a diverse, beautiful people with beautiful traditions. And I think to think about us, particularly as a monoculture, is really is dangerous, right? As you heard last week, I'm born and raised in New York City, Jackson Heights, a very diverse community. And really, you know, I saw Cubans, Puerto Ricans, Dominicans, and an occasional Mexican. But oftentimes when you think of this, when I walk into a room, everybody thinks I'm Mexican. But in New York, everyone thinks I'm Puerto Rican, right? But I think the beauty of that is that at least we're in this sort of ballpark of the Latin culture. But again, we are a very beautiful, diverse population. Next slide. And with that, as you mentioned before, is you said, we are big, we are strong, and we are wide, right? And so thinking about someone from Mexico to Argentina, their culture, their lived experience is completely different. Next slide. And as a Salvadoran American, I cannot assume that I am familiar with all cultural food practices of US-based Hispanic or Latino communities, let alone food cultures from around the world. Now, I would love all of us to think about, as I am, whatever you are, right? Think about that quote. It is with cultural humility, not competence, because we'll never be competent in everything, right? It's that humility that really it's really important to understand that I constantly seek to ways to expand my knowledge and understanding of others so I may provide better and more tailored advice. Next slide. And I believe last week there was a mention of this pivotal study. It's somewhat old. It's 2014, the American Journal of Clinical Nutrition. But really, this is a large study looking at what among the people of Hispanic backgrounds truly eat. And I did this purposely. You know, I wanted to show you that for the most part, right, we sort of eat the same sort of patterns, right? You can see sort of how that graph goes up and goes down. So there's not a lot of variability. But next slide. When you take a little deeper dive into what we eat, and the way I talk about what we eat is very simple, right? Because we eat fats, we eat proteins, and we eat carbohydrates. And as you can see, the percentage of energy from fat range from a high of 32 to a low of 28. So that's not that much of difference. And if you ever spoken to a Cuban doesn't eat Dominican food, and the Dominican doesn't eat Cuban food, right? And so a Mexican doesn't eat that either. So when you're thinking about the ethnical variances, right, we have to be really humble about the differences across different populations. But if you look here, the protein varied little across backgrounds, you know, as well as carbohydrate. What I found interestingly, you know, is how we call a carbohydrate. And I can't remember who said it earlier. It's not carbohydrates as a unified sort of group. It's a type of carbohydrate. It's also type of fat and type of protein. Next slide. And this is what I call the Latin pantry, right? So this is our pantry. This is typically, and what I love about it is really focusing on plant-based meals and plant-based proteins. Not to say that we can never eat you know, pork, chicken, or beef, but again, focusing on our pantry, our culture. Next slide. And by the way, I know I'm talking a lot about food. For people that weren't here last week, I'm also a physician, by the way. So I talk a lot about food and kitchens, but I also feel that the Latin American food, right, that we eat today is sort of, is so, again, so delicious, but also it's very rooted in our indigenous culture, but also our Spanish and African foodways, right? And so we look at sort of more of our African American sort of Latino populations. They're more in the Caribbean, and their foods, although if you think about it, are not that different. I'll share with you a little bit of these variations, regional variations. Caribbean foods typically follow and compare to different from people from Mesoamerica and South America. But yet, we heard last week, from top to bottom of Mexico, it's a huge difference of, again, cuisines and dietary styles. I also like to say that, you know what, if you actually get someone from Italy, from some northern Italy and southern Italy, completely different, right? Let alone think about the continent of Africa, right? You have northern Africa and southern Africa, but yet we think about African cuisine as a monolithic too. So next slide. But really what major differences really relates to the spiciness. And spiciness doesn't always mean hot, right? We associate with spiciness, caliente, picante, right? More with Latin foods, unique to Mexico, right? But again, if you ask many Mexicans, they don't really focus that as sort of the major taste profile. It's part of a blended sort of palate. Cumin and oregano and garlic popular all over Latin America. Next slide. And then using vegetables of flavor, I think what we look at, I love the idea of my plate. I think, you know, 50% of fruits and vegetables, 75% fruits and vegetables. But again, a lot of what we eat as Latinos, right, people of Latin American heritage, really are hidden, right? And we can't use that sort of my plate. And I've done experiments with my patients, right? I'm making a plate and I tell them how much of vegetables in here, how much of starches, how much of protein. And it's really hard to understand, right? And this is where the language has to differ. Sauces, salsas, right, are made from vegetables. Chiles, tomato, onion, avocado, right? Moles, right, are again, using chocolate. Soups and stews, caldos, those are really how we eat. Vegetables and crunchy garnishes. Curtido, actually, my wife just walked in about a minute ago from a farmer's market. And she bought some fresh cabbage. And so today we're going to start fermenting our curtido. Pickled onions are popular in Dominican Republic cuisines. So we do eat a lot of fruits and vegetables, but again, not in traditional my plate point of view. Next slide. And again, I know Angie will talk about this in her sort of sections later on, but really honoring our way of eating. Really, I think Always has done an amazing job of, again, using this pyramid that we often use, right? We're really sort of laying it out. What I particularly love the most of it all is that this bottom sort of the foundation, that to be physically active is so important, right? A walk to your farmer's market. You have to walk. And again, not a lot, 30 minutes a day, 5 times a day. That's 150, 150 minutes. But also, I love this, the community part of it, enjoying meals with others. Next slide. And so the bottom line is this: the Latin food is rich in history, diversity, and culture, each with their own viewpoints, flavors, and customs and traditions. There are many similarities, and I believe there's more similarities that unite us than differentiate us. Every food culture has nourishing, delicious food, and our food culture needs and should be deserved to be celebrated, not hidden, right? And I think if we allow our patients to come out and share their food ways with us, we will learn a lot more, even us as Latinos, right? I always learn more from my patients who are particularly from the Caribbean. As you know, again, New York, heavily Puerto Rican, Dominican, and Cuban sort of influences. Understanding of worrying about learning everything there is to know about a specific food culture. This is why I think as a society, we're moving from competency to more humility, right? Making your patients and clients get the information they need in their ways that fit their life and tastes. With that, I pass to the next amazing speaker here.
All right, I'm going to transition to talking about obesity and go through this very focused because I know we're here to also watch the amazing cooking demonstration that Dr. Angie is going to present. So the last thing I'm going to discuss is obesity. So obesity is important to recognize is a medical condition, right? It's a chronic, relapsing, multivariable disease, and it is at the root of many of these other chronic medical conditions that you see listed below. So especially in the recent past, the question has been, is this something that we should treat, obesity itself, or should we focus on treating the sequelae of obesity? Next slide, please. And so as an obesity medicine boarded physician, absolutely, it's something that we need to treat. We need to talk about in a very sensitive way to our patients, but also define it and let them understand what it is. And so when we make that decision, and when we have that discussion with our patients and make the decision to treat, it's important to establish treatment goals. One of the things I just want to bring attention to is just be cautious of relying solely on just a total weight on the scale, solely on just BMI. I discussed earlier just some of the complexities and the imperfections with BMI. Total weight doesn't take into account what makes up that weight. So I also offer you, if you have access to body composition measures like visceral adipose tissue, percent body fat, absolutely use those, but get out that handy tape measure, right? And use that to just put it around the waist and the hips. Use that as also your treatment goals as well as lab values. Next slide, please. So here, I'm not going to go through each of these drug classes, but as Dr. Ponce had mentioned earlier, we do have pharmacotherapies available, FDA approved for the treatment of obesity. And so it's important to have these discussions with our patients, talk about what the options are. Cost is absolutely something that needs to be present also, and also realize that certain insurances have different policies about whether or not they cover these medications. What I do want to bring attention to as well is that there are generic forms. And so become familiar with generic forms, prescribe those. If insurances don't cover name brand anti-obesity medications. Next slide, please. And then lifestyle. We absolutely need to use lifestyle medicine in the treatment of obesity too. So when we're talking about nutrition, we want to focus on whole foods, right? You've been hearing this constantly throughout. Here on the right, you see a pie chart of the total daily energy expenditure. And I want to draw attention to that orange slice, which says 10% of what makes up total daily energy expenditure. And what's in the blurry lettering there says thermogenic effective food. That means How many calories does our body need to expend to digest food? And so we want to maximize that as much as possible. It's 5 to 10%. So let's get to that 10%. What foods maximize thermogenic effective food? Fiber, protein. So that's what we need to really promote with our patients. Movement. You heard this too, right? Get moving, get moving. That really helps improve the percent of the pie chart of physical activity for the total daily energy expenditure, as well as help build skeletal muscle mass, which does contribute to our basal metabolic rate. Sleep, stress management are also key in lifestyle management of obesity. Next slide. Dr. Angie, I'll pass it to you.
Yeah, so as everybody's sort of learning more about how do I implement this in my practice or how do I get started, for those of you who are in an academic center and take care of patients who are in underserved populations, there is a lifestyle medicine HEAL initiative scholarship. So you can get free certification for lifestyle medicine board certification. There's also new residencies that are implementing this because, again, this is the foundation of where everything in healthcare should be heading towards. And so how can we empower our medical community to also have these foundations as part of their practice? Next slide. All right, then last week we started off, so I like to start off with, if we're kind of envisioning all cultures, all diversities, let's go ahead and just start with spices. So last week we took on spices and we saw an amazing chimichurri sauce and how it was used in different ways. This week we're going to focus on tubers because tubers, I like to explain to my patients, are complex carbohydrates. And like I said, the first word I remember hearing when I was 5 years old was fibra. Does it have fiber? Because that's what you've got to have is more fiber in your diet. So one of my favorite things, vegetables, root vegetables that I like to hear, that I like to cook with is jicama or potatoes. My kids love potatoes, not the French fry kind, but the ones that are homemade that we can actually use as part of as whole as possible, right? So this is a jicama. It is a root vegetable. It's a tuber. It's complex. It has a lot of fiber. So for one serving, it has 7 grams of fiber. It looks like this on the inside. If you're going to buy it, make sure it doesn't have any blemishes or bruises on it. It has a very thin skin, so you cut it in half. I'm going to go ahead and set myself up here. Okay. So
Angie,
I'm going to
can I say one thing? Can I say one thing? Because I would be remiss if I didn't. Because someone brought it up earlier. You know that quote I said yesterday, if it comes in a box, it's probably not healthy. But if it comes in a box, probably eat the box because the box probably is made from fibrous materials. So why not eat the box though?
That is so true. That is so true. So my favorite thing, and I know all of you guys, all the speakers here agree, but I always ask patients, like, where was your fiber today? What was your fiber part of your meal? Because I want them to start measuring that versus calories versus carbohydrates. I want to know what the fiber content is. So I think last week we didn't do a cooking demonstration, proper knife skills. So I'm just going to do that real quick because my husband's an ER physician and he reminds me this is very important to make sure that everybody knows how to hold a knife. So if we're holding a knife like this little ridge right here is for our middle finger. And then you grab the knife with your index and your thumb, and it's sort of a rocking motion. And this stabilizes. So instead of using your index finger, although I'm not going to tell anybody if they've been cooking and home cooking and successful, I just want to make sure that ergonomically and safety-wise, you know how to cut. Okay, so if we're going to demonstrate with this hand, so this other hand is used as a claw, and you just grab your piece of fruit, and what you do is you use the knife against your knuckles. So not splayed out like this, because you don't want to cut your fingers, but against your knuckles. And then you just do it in a very smooth fashion. And so this is what the jicama looks like. And when you can use a peeler, it's a very thin skin. You can just kind of peel around it. And it's a very thin skin. So I've already used this one, but we were talking about Takis. And I will say that my kid has introduced Takis. He's now going into middle school and introduced them to our house. But I also encourage him to do an after school snack when he gets home. And he's sort of done this after school snack that I'm going to show you today. And this can be any kind of fruit. You can also use, in combination with this, you can use some sweetener or some fruit in it. But so I cut the jicama into little sticks like this. And then I have him use some acid. So these are very sweet, but mild, and they take on a lot of flavor. So you can throw them in and they absorb any kind of flavor. So again, we're going back to our herbs and our spices. Maybe this is not something that is culturally appropriate for you. In that case, maybe you want to use a different tuber. You want to use some yams or sweet potatoes, or even some yucca. You can use those as air fryer. I have my air fryer right here. So I always like to see what is part of your culture, and then how can we make it so it's part of your diet now, and you can make it and whip it up, and you're authentically introducing that to your family meal. So I'm gonna put this jicama in here. My kids love cilantro, but they don't like anything else green, but they love cilantro, and that's because they've been eating it in all their foods. So again, anything green goes in my book. So the more I can incorporate it with my kids, the better. So I'm gonna put the lime juice, again, your vitamin C. Combine that up here. I'm gonna put a little bit of some vinegar, like a tablespoon. And this is a chefy thing. I think Dr. Rob knows this, but when you combine two different acids, it makes the dish come alive. So, you know, sometimes you'll see, well, why does it need two different acids? There's just something that makes it extra special. Maybe Dr. Rob can actually say why, but there's something about the complexity of two different acids coming together that really make that, I don't know, make it good. Okay, I'm gonna put some salt, some pepper, and then all of you guys have this, I'm sure. This is tahini. We buy it in, you know, super size, because put it on everything. You can put it on fruit, you can put it on veggies, cucumbers, anything, but it just makes that spice taste much better. So I'm just gonna put a little bit in here. And then you can leave this marinating, or you can do it as, serve it ready to go. I can add a fruit to it, like pineapple or mango or watermelon for the summer. And if I was taking this to like a barbecue, I would make a big batch of it, right? And you make it look nice and pretty. You put it on a plate. You can put different colors on it. And then now when you go to your family gathering and everybody's serving up their meat and they're serving up their tacos and everything, you bring this fresh salad, and then everybody starts saying, oh, it's so good, it's so good. And then you can talk about, oh, well, you know, it's because it has a lot of fiber. And if we eat more fibrous foods, our diabetes is going to be under better control. Simple as that. And it keeps for a really long time. So you can leave this jicama on the shelf for about 2 weeks. Once it's cut up, you can leave it in the fridge for about 3 days. So a lot of times if you have a salad that's sort of wilting, you add a little bit of jicama. It sort of gives it that extra crunch, that texture, and it just brings up and brightens up that salad. All right. Do we have any questions? And that's all I have for you guys today. Do we have any questions in the audience? The pharmacological tools. Yes, thank you, Allison, for saying that. You know, I'm obesity medicine trained as well, and I know Dr. Sobel will agree with me, and Dr. Ponce as well. The more we can help our patients achieve those lifestyle behaviors, the better. And these medications are not a crutch. They're not an easy way out. If you incorporate them mindfully, intentionally, with, you know, active lifestyle medicine management, they can be what the patient truly needs to accomplish their goals.
Thank you for saying that, because tirzepatide changed my life. So thank you.
Thank you all for coming. I don't know if any of you missed our last webinar, but I'm going to go ahead and have, I will throw it in the chat if you guys want to go ahead and watch the recording if you've missed it. And after this webinar, we're going to send out the recording with another survey. We'd love to get information. So if you can give us any tips going forward, anything you took away from it, anything you learned, and then share it. Share this webinar. We're going to have 4 more sessions. So if you can share them with your friends, your family, your colleagues, We would appreciate that. All right, everybody. Thank you so much for sharing your time with us and for coming on board. We look forward to seeing you next week. We're going to be talking about the Latino overarching longevity from different generations, and how that ties together. Really looking forward to seeing everybody.
Thank you all so much. That was outstanding. We appreciate you all so much. Thank you.
Thank you. Thanks, everybody.
Bye-bye, everyone.